these are rules that I sort of started when I first started teaching, not intending to use them as rules. On rounds, we would see a patient, and someone would say something that didn't quite fit the situation. So I say, you know Hall's rule, and I make these numbers up. Hall's rule number 7 is, and to make it an educational experience for the person who had made the observation. And that just grew slowly over the years. And I have many more rules than this, but these are some of the ones that I remembered to put down that were published at my FEST trip in 2003 or 4 in the American Journal of Medical Genetics. I might tell you that my ex-fellow, John Carey, the editor of the journal, was the one who wanted me to put these in, because he learned from these rules and thought they were worthwhile. Most of you know that I'm at the University of Kentucky, and that basketball is big there. So these are some of the things that do's and don'ts. I shouldn't say do's and don'ts. These are to be guides to think about how you're going to deal with various conditions. Hall's rule number 1, never make a clinical judgment on a measurable parameter without measuring it. Here are an example of, on the left, the Marfan's individual who has true arachnodactyly by measurement as well as the suspicion thereof, just looking at the fingers. The thinner the fingers, the longer they look. And in this situation, they look like they're very long and obviously very thin. This is the hands of an individual with Cohen syndrome who has decreased muscle mass in a generalized fashion, but very dramatically in the digits of the hands and feet. Here are 2 individuals one who has true hypertelorism, Waardenburg Syndrome, and that's by measurement from the mid pupil to the opposite eye mid pupil. This individual looks like they're hyperteloric, but it's artificial unless you measure this distance here to find out that it is in fact normal, but this distance from the medial canthus to the medial canthus of the opposite eye is increased, and this is called dystopia canthorum. Continuing with that same rule, here's a boy who is microcephalic, significantly so. That gives the impression that the ear, in fact, is large. Almost every patient with, unless they're syndromic microcephaly, will look like the ear is large. It's also overemphasized in this situation because the mandible is also small. But by measurement, this is a normal size ear. Here's a boy who does have large ears, but they're proportionate to the rest of the individual's size and head circumference because he has the overgrowth syndrome, the soda syndrome. So always look at adjacent structures when one's evaluating size, as well as many other aspects of diagnosis. Continuing with this, we have an individual with Russell-Silver syndrome. He looks like his head is very large, but in fact it's at the 3rd percentile. The reason it looks large is that the facial structure here, bone structure, is so reduced that it gives the impression of excessive size. And many of these kids with Russell-Silver syndrome were subjected in the early days to pneumoencephalograms, looking for enlarged ventricles to rule out hydrocephalus. Here's a nice comparison of a boy with soda syndrome and a boy or girl with Russell-Silver. They have both large appearing heads and triangular faces. The difference is this is real and his face, while it's triangular, is large, and this boy is triangular, but the facial bone structure is small. Rule number 2, Gestalt diagnosis is a dangerous technique.
Dr. Hall,
Yes.
can I ask you a question about rule number 1?
Yeah.
Just in general, is it practiced now that people are measuring all of these things? Because frankly, when I go into the clinic with my son these days, we're in and out so fast, I can't believe it. I'm just wondering.
You're asking a question you know the answer to.
I think so, but I'm just curious about your opinion right here.
Measuring these observations,
Takes time.
well, it takes a little time.
Okay.
It'll save you time too sometimes, but it's not done regularly. What the point is that you should do it if it's critical to your observation and if you're adding that particular feature to the list of dysmorphic features of the patient. But it's not done regularly. I hate to tell you this, but a good physical exam is not done very well anymore, and it's done very abruptly without good observation. And this is why these particular rules, as old as they may seem, are still very important in the physical diagnosis and observation and the documentation of the physical characteristics.
Is it the pediatrician or a geneticist?
It doesn't make any difference. The geneticist is not, they don't like to spend extra time measuring either. And they think they're so good that they can always tell. They're better at that than the general pediatrician or general journalist or any other physician, but they're not at all infallible. The Gestalt diagnosis is a dangerous technique. This is walking in, when you immediately see somebody, you say, got it, that's it. Well, that works. If you've seen a number of cases of this, you have a good feeling for the syndrome, but even then, people will make mistakes, because what you've got to do is you have to say, okay, I think that patient has this just by this immediate appearance. Then you have to dissect why you think those features make that patient have this particular feature. And of course, this relates more to the face than to any other exam. But here we'll show you, and you'll see some other slides in future slides, with an individual who has relatively severe Delange syndrome, very classical features. And here's a mild Delange with the same features, but looks much more mild. And then I will show you a patient who looks like this who does not have Delange syndrome. And so if you could stop this patient and the other patient I'm talking about with Delange, you'll be right 50% of the time, which is not a good diagnostic average. This is a child who I diagnosed as that mild Delange. At the point we saw this patient, there was no gene available, no testing to identify Delange. And as I followed this patient along, he began to look more subtle and more subtle, to the point here, I wouldn't have diagnosed him if I had seen him at this age. I think he was around 18 or 20 months. And he is also developing normally. All these indicate that my original diagnosis or suspicion was probably not correct, and it turned out not to be. Here's a boy who has true Coffin-Lowry, wide-spaced eyes, large mouth with everted lower lip, and this is another unrelated individual who has the typical proximal puffiness and distal tapering that's so characteristic of this particular disorder. And here's a family that I recently thought this boy could have Coffin-Lowry. There was mild tapering. In the pursuit of diagnosis, we often tend to stretch a little bit, and you got to be careful when you're stretching. It's okay to stretch a little bit, but not to make a specific diagnosis or irreversible diagnosis until a family has what it is and have to go through the song and dance of what it means for the child. This was the family of this boy with the father had the large lips, the wide-spaced eyes. Here's another sibling. And I've seen another family with this type of facial gestalt that looked originally like they might have Coffin-Lowry, but did not turn out that way. Rapid diagnosis is a diagnostician's aim as well as his cryptic enemy. Again, this gets back to Gestalt, but we all want to make a diagnosis and give accurate counseling and intervention when it's available. But here are two patients that do in fact have Menon syndrome, but they originally were not thought to have. This boy had no cardiac problems, was not short, his ears were not low set or thick, his eyes were not widely spaced, but he ended up having Menon syndrome later by molecular testing. This boy looked like Menon's, but he had a coloboma of his right iris, and at that point there had been no reports of coloboma in the literature with Menon syndrome. Since we published this in a letter to one of the journals, there has now been about 8 cases of Menon syndrome with colobomas of the iris and or of the choroid. So when you find a feature that's not normally part of the syndrome, don't chuck it away and say, well, this is makes this a different disorder, or this is a very low frequency feature. Just put it on the back burner and look for other cases. Again, rapid diagnosis is the diagnostician's aim as well as his cryptic enemy. Here's a boy who was very Menon-like. He had a pectus, mild webbing. He did have some hypertelorism, and you can see more dramatic downslant than most kids with Menon's have. He had this hair that was sparse. We didn't know to look at that point in time at the hair shaft, which we should have, but we didn't do that. So we continued to follow him up, and as he grew, we also noted that he had this more of a brown pigmentation, and his hair became a little bit more generous, but still sparse, but it became curly. And we eventually, when the gene for this disorder was reported with loose anagen hair, which is what this is called, that's a very early stage of hair in the normal hair development in the fetus, that he did have shock 2 and was in the RAS pathway. Time is the greatest diagnostician. Now, this is not something most of you deal with, because at least half the patients I used not to be able to diagnose, you can diagnose now by the new laboratory test that you get back reasonably soon, after, particularly here, after you've ordered them. But for this particular girl, here she is as a neonate or as a young infant, very dysmorphic, high set nose, vertical creases here, was very undergrown. And as she got older and we continued to follow her, she remained very dysmorphic. You can see this epicanthus inversus here. You can see these creases here, which became more dramatic as she got older. And we followed her for 12 years, almost 12 years, without a diagnosis. And we had done all the analyses from a laboratory standpoint that were available at that time, except the array was just coming out. But before we had an opportunity to do an array, the dentist called me up and said, your patient has cyst of the jaw. Have you considered basal cell nevus syndrome? And of course, this is not the appearance of a basal cell nevus patient at all. But I said no, but I knew well that where the gene for in some instances for keratosis of the mandible existed, and we did a microarray, and we found out that she had a microdeletion of the long arm of the 9th chromosome in the region of the basal cell nevus syndrome, even though she didn't have any definite basal cell nevi or any other feature. It was this particular feature that develops over time in these individuals, usually not before the age of 10, that clued us into where to look for the chromosome abnormality. She had a large deletion. Alternate number 5, lack of diagnosis is most often due not to having all the available information. We talked about that this morning a little bit. It's just usually the result of not delving into the history and the detail that you need, although sometimes the parents don't volunteer this information even when you ask for it. Here's a girl who had an unknown MCA that I diagnosed with a syndrome that I discovered, Charge Association, now called Charge Syndrome. She had corneal atresia. She had coloboma, and she wasn't as hypotonic, and she wasn't undergrown, and she did not develop microcephaly as she grew older, because in Charge, microcephaly develops post-birth, not pre-birth. And her growth was good, and her development was good. When we saw her at about this age, we again asked the mother if she had had any exposures, which we'd asked her before a number of times. And she said, no, but you have to remember that some individuals consider some of their medical problems normal. And some of the medicines, since a lot of people take thyroid, for instance, or other medicines, that's normal. So you don't have to tell the doctor that. But she was treated for hyperthyroidism with methimazole, which is known to cause the phenotype that we have in this child. It does not normally affect mentation. So 3 years later, we altered the diagnosis, and we weren't very fast at reaching this conclusion, but the information was back there, not in the charts, and the mother denied it initially, but we didn't ask the right questions. This is also associated with absence of the breast tissue and the nipple in about a third of the patients. Another feature that's not part of Charge. And here's another patient that, in retrospect, I should have suspected. We assigned him out as an unknown MCA. He did not have short palpebral fissures, and we noted that at the time of the exam, but he had a relatively long and somewhat simple philtrum, and he was hypotonic. At 3 years of age, this was about the 5th or 6th follow-up we had, the mother finally admitted that she had been abusing alcohol during her pregnancy with this child, and we had to change our diagnosis to fetal alcohol syndrome. Even though he had some features, I'm personally very reluctant to use that diagnosis without a history of alcohol intake. A wrong diagnosis is infinitely worse than no diagnosis. Here's a child that I originally thought had, and it's not Coffin-Lowry, it's Coffin-Sears syndrome. That's a misprint. So I thought this boy had pretty classical Coffin-Sears syndrome, and I was involved with the second report of a number of cases, as well as my fellow, we did the third report. So I had a good basis to know what Coffin-Sears was. And the only thing that I should have paid more attention to was the fact that he didn't have really thick eyebrows or long eyelashes. He did have the sparse scalp hair, but I didn't put enough emphasis on what he didn't have and put too much on what he did have. As he got older, he began to become more distinct and more dysmorphic than Coffin-Sears. At least some Coffin-Sears patients that are actually Nicolaides-Baraitser syndrome do have this appearance and do look different than Coffin-Sears. This child did not have, and this is the same individual, did not have nail hypoplasia, as we see in Coffin-Sears very consistently. And he never developed really good thick eyebrows. He's got a little bit longer eyelashes now. He has a sparse scalp here. And this is just a more classic one, patient I saw in San Francisco with Coffin-Sears syndrome with the relatively sparse hair. It doesn't look sparse, but it is, and thick eyebrows and long eyelashes, and pretty typical patient. Nails missing or hypoplastic on the hands and sometimes feet. if you won't consider selling your firstborn for diagnosis, you aren't a great diagnostician. People who take making a diagnosis really seriously are going to go to many lengths to make it. Because we used not to have all these support type of testing that could rule out things quickly. So we had to look at every aspect of the patient's physical characteristics. We had to do a laborious review in the library. I spent so much time in the library that I now have dust to allergies to library dust. Anytime the fans come on in a room in the library, I start coughing and sneezing. And that's where I developed it, because I didn't have it before I did that. That's my diagnosis. This is a very unique patient. We still do not have a diagnosis for this patient, but I haven't given up on this, and each case that's reported with one or more of these features, I look at it very carefully, hoping that we will eventually diagnose this patient. This patient had very abnormal nose, very short palpebral fissures. These eyebrows are going down into the lateral border of the left and right eyelid. He had hypoplastic thumb. He had deafness. He had cranial synostosis. He had all these things that one would think you could find another case of, but we couldn't. And Dr. Mike Cohen, who I sent a full report with about 40 pictures and x-rays, could not also identify it. And of course, he's one of the experts on cranial synostosis. But I haven't given up. So always continue to keep these patients in your mind as you look through the literature, as you see other patients. Tenacious pursuit as a diagnostician's greatest trait. And again, that falls back on what we were talking about in number 7, is you want badly to make the diagnosis, but you don't want so badly to make the diagnosis that you jump to a conclusion. If it doesn't fit, it doesn't fit. And if it doesn't fit, it doesn't mean it's not what you're thinking about. You just have to make it fit without forcing it. This is an individual who I saw when he was about this age, and he was slow. He had some orthopedic problems. He had very high arched eyebrows. It doesn't show on this particular feature, but they're very high and U-shaped. He had some mild facial aberrations as well, teeth aberrations. He had fusion of his radius and ulnar bone. He had a pseudo tail, which I'll show you in a minute. And I sat on this child for probably 5 years, following him at least once a year, sometimes twice a year if he developed new issues, to come across a syndrome that had lots of clefting that altered the physical characteristics of the face. Carnival syndrome was one of those. And there's now 4 syndromes that look like this, but they have varying degrees of difference. And that's one of the reasons I didn't come up with that diagnosis, but I had some good markers to look for. The radial ulnar synostosis was one. The pseudo tail here is another. This occurs in about half the patients. Here's the radial ulnar synostosis. So despite him having a lot of unique features, it took me personally 5 years to find a match for him. And this is a pseudo tail because humans don't really have true tails. They lose their tails very early in embryological development, but this is often a prominence of the lower sacral area. It's not a lipoma, it's a bony protuberance. Observation of minor and subtle features separates a great diagnostician from other diagnosticians. It's another way that Sherlock Holmes, when asked why he was a better detective than his colleagues, said, "I pay attention to trifles." Because most people are not going to miss major physical features, but many people miss minor ones. Things that in an additive form, or if they're rare, can be very useful. Here's a patient that has very close set creases, flexion creases of the fifth fingers. He was born with a small head, and he had duodenal atresia. And I was aware of this particular syndrome only because I paid close attention to gut atresias and their association with various malformation syndromes. So we got the mother, measured her head size. It was also microcephalic. We looked at her fifth finger. It was short, and there was a single developed crease here, and a very hypoplastic distal crease. This finger normally should come up to about here. And she has a hypoplastic thumb as well. And she was born with duodenal atresia. And that was something that had not been obtained as a history before we saw the patient. So this is Feingold syndrome. And it's just those small things like that can help you make a diagnosis. And there is a gene for this now. Paul's rule number 9, observation of minor and subtle features separates, well, I've already done this, haven't I? Okay. The point here is that this is omphalocele and macroglossy. The patient presents like that, you're going to say Becker-Wiedemann syndrome. And he also had, this is the same patient, he also had these creases on his earlobes. His mother, however, had no other features except this. She had a sister who had a child with Becker-Wiedemann syndrome. So they were obvious carriers, but neither of the sisters would have been diagnosed had they not had affected children as carriers or affected. So you need to be very diligent in looking at parents and siblings. There are no minor features when it comes to diagnosis. Most malformation syndromes are made up of minor features, or minor anomalies. It's the rare syndrome whose majority of their features are major anomalies. So you need to pay close attention. And if they're unique as this is a triangulated philtrum, which is very unusual. It's sometimes called a pseudocleft, particularly if it's unilateral. It's found in this particular syndrome. We did not originally make the diagnosis, although I was one of the original describers of this syndrome, because this patient had nothing else very dramatic. And the first time I did pay attention to this. Normally there's a post-auricular hemangiomatous lesion in these individuals with the Boffer branchiootofacial syndrome. But the second time I saw her, I saw this and I said, well, I've never seen this reported. So we did a quick check of the literature. It had been reported once before, and it's been reported a number of times since. So hair where it shouldn't be, but where the major physical finding usually is a good marker for suspecting this syndrome. Here's a girl who's slow, has low set ears, had some other minor features. Was classified as an unknown MCA, but the mother brought it to our attention that she had hair growing under her chin. And there was loosely a description of the number of patients, maybe 6 or so, under the diagnostic term hairy throat. But within this group, which has grown numerically quite a bit since the late, let's say, 90s, has been a number of malformation syndromes that are autosomal dominant. And she probably fits into one of those. I haven't seen her probably for 15 years. But something as simple as this can lead you to a diagnosis. So pay attention to those things, particularly if they're rare or if you've never seen them before. That makes them rare to you. Paul's rule number 11, determining what a patient does not have is just as important as determining what he does have. And here's an individual, both are pretty clear-cut Prader-Willi individuals, not because they're obese, but because of their facial structure, their short palpebral fissures, their almond-shaped eyes, the smallness to their head, the history of hypotonia in the newborn and neonatal period, that eventually improves. Problems with skin repairs from scratches, you can see them there. Small hands and feet. So the fact that he's obese, both of these kids are obese, is just one feature, with all the others contributing eventually to the diagnosis. Here are two boys that look similar. They're perfectly normal, had no hypotonia. For every, I would say, 10 patients I see to rule out Prader-Willi, one of them has Prader-Willi, the rest are mostly environmental obese kids who had no lineal history of hypotonia. I'm reluctant, and this is proven pretty much true, that if you don't have hypotonia as an infant, you don't have Prader-Willi, regardless of the other features. Here's a patient that illustrates the pursuit without knowledge is better than knowledge without pursuit. We see a lot of very bright, intelligent individuals who just don't pursue diagnosis. If it doesn't immediately come to them, either because they're smart or because they've read a lot, they just don't pursue it. And the pursuit is very, very important. And this particular patient, when I was in the Air Force, was born at the Air Force Base. I was asked to see this child and knew that he had a defined syndrome that I could not remember. I looked under limb reduction. I looked under lots of different features that this individual has, even hemangiomas, which you see here, epicanthal folds as well. This is not the same patient, but with the same disorder that I saw in Lexington, Kentucky. And one of the things about going through the literature, either with your computer or going through the journals that come to the library, you never know what's going to pop up the next day with that diagnosis that you couldn't come up with. And in fact, the next day, I came across an article that was called pseudo-thalidomide syndrome, or sometimes Roberts when there's severe clefting of the face. And it's also called SC Focomelia syndrome. And this was in, I would have been in the military in 1971. And so this syndrome had just been described by John Opitz in his group a few years before that, but very few other cases. This is another example of that rule. This is a patient I had from the Clinical Pediatrics Journal in 1969. He was reported, whoop, I'm sorry. I want to do that. He was reported as a progeria patient. And I can see why they did. He was very thin. He looked much older than his age. He had lots of skin problems. And that particular report, including little unusual lumps on his fingers that nobody made much attention to in the report. But for some reason that made an impression on me. I took the article out of the journal and I put it in my progeria file, because I had files that not only have a particular syndrome in them, but other reports that look like they might have it that are unknown, that I can refer to back, because many syndromes are originally reported as something else that they eventually turn out not to have it. But how are you going to find these disorders? And this is the way I did it. Well, in 1997, in the American Journal of Medical Genetics, this patient was reported. And they're identical, and they're the only two cases. Well, now there's a third case that has been reported with the Kahneman-Penttinen syndrome. It goes now by Penttinen. Unfortunately, Penttinen didn't originally report it. Kahneman reported, but I've added his name as part of the syndrome, and it's listed in my files as Kahneman-Penttinen syndrome. Here's a typical charge patient. Very classic ear. If you see the lower portion of the ear missing in a charge syndrome in a patient with multiple anomalies, you should always think of charge because that's an unusual ear abnormality. I only regularly see it with any consistency in charge in infants of diabetic mothers. Follow-up is the diagnostic ace in the hole. This patient I saw as a newborn. He was hypotonic. He had coarse facial features. I thought, as did other people, that he probably has some type of storage disorder. We were not able to verify that by various testing, and we followed him up until he was, he was many years of age. But after the fourth follow-up, which would have been at about 3 years of age, when we saw him, it was clear that he had acanthosis nigricans. He had become even more coarse, but when we saw the acanthosis nigricans, we obviously wanted to look at those disorders that have insulin insensitivity. And his insulin levels were extremely high, and this is typical. There are other features now in retrospect we can look at. He always had very prominent nipples that were always erectile, and he had other features as well. And the disorder is called Menon syndrome. So one of the reasons to follow patients is to pick up new features that give you new clues. Inadequate histories and not seeing a patient's relatives, either by photograph or personal exam, guarantees the diagnostician great embarrassment. So here's a situation where we saw this patient first, because this is his hand. He had a triphalangeal thumb, which is a long but thin thumb, and usually with 3 phalanges rather than 2. And in asking the history, he said, well, I've got a sister, her thumb's a little bit funny, and I've got a nephew and niece that have stubby thumbs. Well, at that point in time, there was no association of this disorder, Townes-Brocks syndrome, with those type of thumb abnormalities other than triphalangeal thumb. None of these individuals here, had any degree of deafness. But when we did bring them in to see, they had these type of thumbs. They had stub thumbs, very broad thumbs, more narrow proximally. Here you see the 2 children, these 2 individuals with the same type of thumbs. In one case, very hypoplastic flexion creases. And as this syndrome has grown numerically in those cases reported, that's not an uncommon finding to have these broad stub thumbs when the original classic report is triphalangeal thumbs. This girl came into our Whitesburg clinic, which is on the Kentucky-Virginia border, had this big nose, very retracted lower maxilla, had web neck, was mentally normal, had a pectus excavatum. We asked if anybody in the family had any of these features, and of course most said, yeah, but it looks just like her father. They weren't really very concerned about this young lady. So we got him, went out to the parking lot, and got him out of his truck, where most of the fathers are in eastern Kentucky when they send the rest of the family in, because they don't want to get their blood drawn. And here you can see his broad chest, the pectus excavatum, webbing of the neck, and similar features. We don't have a name for this phenotype. It's obviously a single gene, but at least we know it's inherited and what the recurrence risk is. And because the father's older, we have some idea about the prognosis. This child was, I keep pushing the wrong one. Sorry. This particular child here came in because he had a hearing loss, had hypoplastic nasal bridge, had questionably wide-spaced eyes at that point. We thought he looked like he had Waardenburg Syndrome. And we asked the mother if she had any problems, and she said no, and she had no deafness. no heterochromia, had obviously a very different nasal configuration. At that time, I didn't really pay much attention to what happens to the nose in Waardenburg's. I do now know that they start out with this type nose, and they end up with this type of nose. Go a high narrow bridge and a prominent nasal tip, as opposed to an upturned flat nose with a flat nasal bridge. We then went and got pictures of the mother when she was a little bit older but young, and you can see her facial features are quite similar to her child's and as she was as an adult. So sequential photographs can be very useful, particularly if the phenotype changes. Here's a grandmother and two of her grandchildren showing you the changes in the nose. This is the younger boy. He has the upturned nose, the flat nasal bridge. His older sister has started to develop the nose, and she's starting to have a prominent tip. And here's the grandmother, look at her nose, look at the prominent tip. Just the opposite of what it was as a neonate. So these are the types of things that can help you suspect or make a diagnosis once you know that that's the normal occurrence in Waardenburg syndrome. This is type 1. If you never learned anything by doing it right, errors create the greatest opportunity to grow and learn. Humble pie is good for the soul. So I always look at errors that we make as learning experiences, and I always try to emphasize this to the residents and the fellows. There wasn't a reason to be embarrassed, it was a reason to be encouraged that they, one, are going to learn something that day, and two, that it's going to benefit them forever. And this is my example of that. Here is a chart of 32 cases of Prader-Willi. When I went to be a fellow with David Smith in Seattle, the first week I was there, he gave me a patient with a multiple anomaly syndrome. And this patient had hypotonia, was a little bit overweight. At that point, I think it was like a year of age. Had unusual eyes. So I recognized, in small hands and feet, I recognized all the features, but I didn't have a clue as to what it represented. And the medical student who had been there the week before, Dr. Smith asked him what he thought, and he said, Prader-Willi, classic. And so I got shot down the first week by a medical student, and that sort of stimulated me. So in the next 2 years before I finished my fellowship, I'd rounded up 32 cases and reported the first American series of Prader-Willi syndrome. So it made a positive impact on me. It changed a lot of the ways that I think. I've been involved with the Prader-Willi Parent Association for many years, so you never know how long those type of errors will give you a new outlook on certain aspects of diagnosis and syndromes. Hall's rule number 17. Ray said today that he assumed. And I said, I should say something, but I'm not going to do that because he's done such a good job. I guess if you do assume, you need to know that that may not be correct. And there's many times that I've assumed things over the years that have ended up with a wrong diagnosis or making a mistake in many different ways. But these patients, before the charge association was well described by me, just were considered to have an mental retardation, multiple congenital anomaly syndrome. And I assumed that they were mentally retarded, which was a proper assumption because all the kids I saw were either in the newborn period or by chart review, and those were mostly newborn period times. Those children were deaf. They couldn't see well because of colobomas. They had serious heart disease, so they were hypotonic. So all the early suggestions were that they were mentally retarded, although this was not over a long period of time. As we've come to learn that some patients with Char syndrome are not mentally retarded. And there's no particular factor that influences whether they're retarded or not, from a physical standpoint. Here are two boys. This boy has a normal range but low normal IQ, and I followed both of these kids for a while. Here's a child, another boy who's also in that category, and they all had pretty classic charge association. So when the parent group first jumped on me at a conference, when I said that 100% of the patients are mentally retarded, we were still using that term back then. A number of the parents got up, my child's not retarded, my child's not retarded, my child's not retarded. And I had to reevaluate that and look back and see what that was based on. It was not based on a time factor, and it was not based on the limitations these children had in order to make a proper judgment of their mental skills. And this is a patient, this has a lot of rules I can write. This is a patient I saw whose only feature was corneal atresia. You can see that the child has the stents in the nose. He had also, I think the other feature that he had was some cranial synostosis. And I could not make the diagnosis of charge based on the presence of cranial synostosis, which hadn't been reported in charge. And there was the absence of coloboma and small penis. So I did not make the diagnosis. Well, that's my first mistake as far as not considering the diagnosis seriously enough. Secondly, we did a chromosome study which showed a large deletion involving the charge syndrome locus. At that point, we didn't know where the charge syndrome locus was. Now, it would have been nice that since I discovered the syndrome, if I could also discover the gene. But it didn't click with me that this patient had charge and that all the features we were seeing were all due to the acute deletion, and that the gene, the classic syndrome, the gene for that disorder may be within that deleted area. So someone else about 2 years later discovered it. And I was glad they discovered it. Boy, was I upset with myself. When you're busy doing stuff, you don't always think of these things, even though you try. Paul's rule number 18, I always assume everyone else is wrong until you prove otherwise. See, we used assume in the opposite way that we used assume before. Never assume, and here I'm saying always assume, because when things get into the chart or on the chart or into the literature, you make the assumption that is in fact true. And always verify, particularly things that are written in the chart, that they in fact are what is the case. Here's a child who was born with severe microcephaly, fused myotopic suture. Head circumference is about 26 centimeters. At this age, a child should have a head circumference of about 33 centimeters, so very, very small. Prognosis, based just on the microcephaly alone, much less the syndrome, would be poor for mental development. But since we had already diagnosed the child with Carpenter syndrome, he had polydactyly, short valvular fissures, pretty typical Carpenter syndrome. All the literature cases said that the children with Carpenter syndrome are mentally retarded. Now, she's a high school graduate. This is the same patient. She now does not have microcephaly because they repaired the cranial synostosis. And so we looked around, and Jaime Frias, who was at Florida at the time, had a case that he not reported with Carpenters that did not have mental retardation. And now it's probably at least, I'd say, close to a quarter of the patients with this syndrome that are not mentally retarded. So you can't believe the literature either. This is another case I had a number of years after I saw the original girl who graduated from college with Carpenter syndrome. Obviously, he's not retarded either. And that brings you back to the point that you can't define retardation just on the basis of physical features, particularly facial features, are not appropriate to make a diagnosis that the patient with those features are going to have mental retardation. There are no natural observers, just inquisitive ones. People who see something and then think about it are the people who are going to make discoveries. This is a medical student who rotated with me, and I could not look at this guy without looking at his dimple on the chin. I mean, it was a big dimple, and I just casually said I had no interest in dimples way at that point. I just asked him, was there anybody else in your family who has dimples? Yeah, he said, everybody's got dimples. So we did a pedigree, which I think I'll show you in a minute, and it looked like an autosomal dominant with about an 80% penetrance, so about 20% of people who were obligate carriers of this chin dimple did not show it physically. This is some of the family members. This is the father. She has a little one down here that you really can't see, and this is the grandfather. Again, note the difference. He's got a more classic dimple. He's got a more cleft or crease, and he has a tear-shaped dimple. So even in the same family with dimples, the dimples look different. And then I started looking at syndromes. This is a short syndrome, and half of those patients have chin dimples. Again, it's on the under surface. You can't see it. These are thin individuals. We're trying to efface these. A lot of other syndromes have dimples, but not an abnormal number have dimples. I always look at the parents and the siblings before you put dimple in as an abnormality. You can put it in as observation, but not as an abnormality. This particular syndrome, which you all are well acquainted with, is not associated with chin dimples. What you see is what you get. There was a comedian, Flip Wilson. I don't know if any of you know Flip. He's now deceased, but he's a black comedian, and he had an hour show every weekend. I can't remember which day it was. And he liked to dress up as different characters, and one of his characters was a female. And he would come in strutting with the dress on and everything, and he'd walk up to some man at the bar and say, honey, what you see is what you get. And of course, that wasn't what they got. But I'd like to change that a little bit and add what you know is what you see, is what you get. So it's important to have background knowledge as much as possible. The eyes don't see what the mind doesn't know. I just added that because that's a part of this, what you see is what you get. Here's an individual with the Lyme syndrome with very unusual high-set nose. We talked about this before, with the lower part of the nose being present and most of the nose, the upper one-third being present, but either absent or very small amount of the mid one-third of the nose. Here's another syndrome. Williams syndrome has the same characteristics, totally different syndrome, but very useful in making a diagnosis or suspecting a diagnosis. And here's a individual that has tetrasomy 12p, and one of the things, there's many interesting features in that condition, but one of the most interesting to me is the incidence of hypopigmented areas, particularly on the forehead, often to the side. This is very typical. There's about 10 cases in the literature, plus I have 4 cases that have tetrasomy 12p with this unusual hypopigmented spot on the forehead. Other conditions have these features that if you look for them, they're usually there. Mosaic trisomy 18, these vertical creases between the 4th and 5th and the 4th and 3rd toes is pretty typical and is a good feature. And I've made the diagnosis, suspected the diagnosis on that basis alone in at least 2 different instances. I'm going to stop in a minute. We'll pick this back up at a time in the future. Just the last one, all features are related until proven otherwise. In pediatrics, we like to take all the features that we see in our patient and put them together in one package. A lot easier to do in children than it is in adults who have multiple diseases with multiple physical problems. Here's a Rubinstein-Tabby individual who has the Hitchhiker thumbs, inverted, the hypertrichosis, the eyebrows, wide-spaced eyes. but also a keloid. And this is a Caucasian child. Keloids are very unusual in Caucasian children. And once it was recognized as something that was increasing frequency, people in rheumatoid arthritis, people started looking for it and documenting it. And now about 20 to 25% of the cases of rheumatoid arthritis have keloid formation as they get older and have scratches and cuts and things of that nature. In neurofibromatosis, this is a rare feature that most people aren't aware of. And these are not neurofibromas. These are xanthogranulomas, or yellow tumors. They pop up new sometime in the first 2 or 3 years of life. They usually last for a year or so, and they gradually go away. Some people have tried to say that their presence indicates increased risk of leukemia. That has not yet been proven. But these low frequency features, some are not so low frequency and others are, but they need to be known about and interpreted. I think that's it as far as we'll go. We'll pick back up sometime in the near future. Appreciate your attention, and make some of your own rules up. There's a lot more to go. Thank you.